I'd like to welcome you all to the first session of the afternoon. If you don't mind, please switch your mobile off or put it on silent. I know it's a bit difficult after this big, beautiful meal. It's difficult to start the session, but I welcome you all to this afternoon. I'd like to welcome Prof. Yang. Prof. Yang, he is a professor in the Department of Anesthesia and Pain Medicine, University of Ottawa, and he is the Director of Professionalism at the same university. Professor Yang has very extensive and wealthy experience in the education and the training programs and training in Canada. As well as that, he did a lot of research, and he has a special interest in the perioperative medicine. And if you behave yourself, Professor Yang might play music at the end of the session, because Professor Yang is a professional music player in orchestra as well. So please welcome Professor Yang to this session. Thank you.
Thank you. I'm going to try this. Shukran Lida Awatikum El Karima. I hope I said that right. And Watahia Laikum Man Canada. Did I say that right? If I could have the slides up, please. While they're getting those slides up, I will start talking about, my topic is about preoperative cardiac optimization. And it is an area that many of us wish there were something that we could do to say, this patient is going to be fine when we do surgery. Unfortunately, I think I would say at the end of the lecture, that's not necessarily the case. Thank you. And I'll give you the reason as I go along. So the objectives, I guess we don't have a projection there, eh? So as I'm getting older, I can't see on the side. So the first thing that we would talk about is what is the state of preoperative screening as we know right now, and we'll try and understand the context of preoperative screening. We also will talk about the understanding of the pathogenesis of preoperative myocardial ischemia infarct. So we are focusing really on the ischemic side of the issue rather than vascular valvular disease or cerebrovascular accidents. And we're going to talk about the potential of how an echo can change. Thank you. Excellent. So we are helped in the sense that there is already an algorithm that the American Heart Association and the American College of Cardiology have put out. And this algorithm is well referenced. It came out in 2014, has been disseminated through a number of organizations, and it's easily searchable on the web for free. So it's not something that is hidden. And you can easily look at the algorithm. If people want me to go into the algorithm in detail, I will, but because of the 20 minutes, I think I will try and spend the time better in giving you the overview of what's going on than actually the actual algorithm steps. One thing I do want to point out is if you look at the algorithm, there are colors of the boxes. That reflects the level of evidence that the American Heart Association has come up with. And you see the yellow, which is class 2 evidence, and you see the red, which is class 3 evidence. Essentially, I will go into the more detail, but it's not class 1 evidence. The only thing that is class 1 evidence is the green box, and you see the algorithm coming down. That reflects the state of our science, which means we really don't have class 1 evidence to do a lot of the things that we think we should do. Having said that, I don't want you to think that there is nothing we can do and therefore we should just go ahead. regardless, and I'll emphasize what the difference there is. In comparison, there we go. In comparison, this is the algorithm that came out in 2014 at the same time, looking at the dual antiplatelet therapy when patients who have a coronary stent coming for surgery. And you can see most of the evidence is class 1 evidence, and that's green box. So you have 3 green boxes and just 1 yellow boxes. There are no red boxes. It reflects that the state of evidence has advanced so fast for the coronary stents, because if you recall, even 6-7 years ago, we were struggling to understand what to do with those patients. But the cardiologists have really stepped up to the plate and answered many of those questions. So that is the state, unfortunately, for pre-op testing when we're talking about anesthesia and perioperative care. But when we're talking about coronary stents, we actually have very good evidence. I'm not going to go into this algorithm for sure, because I understand the next talk is on that. The first thing that we have to talk about is optimization. When we say optimization, it really infers 3 things: that we have a test that we can do, and from that test we can identify what the problem is, what the pathology is, and from there we can do something about it. That's what optimization is. Unfortunately, the evidence is not very good in how much we can optimize. This is a graph looking at mortality, and if you see the 3 lines, the bottom line is the mortality between 2000 to 2008, and it's a vascular group of patients that they've been working on, and the top line is looking at how much beta blockers those patients received. And the emphasis in that paper was to say that increasing the number of beta blockers did not change the mortality in vascular patients. But more importantly, there are a number of studies which will confirm the same finding. Our mortality in high-risk patients, we have not been able to change. It just stays the same. So that becomes a major issue when we say that we can optimize the care of these patients. One of the reasons is this plot. This was published in the Canadian Journal, but there are other plots similar to this, other studies similar to this. And what essentially David Wong found with the senior author is that when you do revascularization, does it affect post-op mortality? That means before the patient comes to surgery, you find coronary artery disease, and you say, okay, we go and do a revascularization, put in a stent, or we put in the cabbage as a procedure. Does it actually change outcome? No, it doesn't. It doesn't change post-op mortality. Does it change post-op MI? Well, it doesn't. So that really puts a big damper, as we say. We can optimize the patient when we actually are not changing outcome, and we don't seem to be able to change the outcome. It's very unfortunate because most of the things that we are seeing potentially changing outcome, and most of us are seeing that in big database analysis, and that's the minimal invasive surgery, as well as the intervention radiology. So I'm talking about, previously we would talk about an open AAA procedure. Now we're talking about an EVAR, a stent in the aortic aneurysm. Previously we would talk about a laparotomy for a bowel resection. Now we're talking about a minimal invasive surgery with laparoscopy and incisions about this big. They get the bowel out and that's it. That actually evidence is stronger and stronger to show that it reduces mortality and immediate 30-day mortality and morbidity. Not what we've been trying to do, unfortunately. Is this new? It's not. In 1995, Mason actually did a study looking at decision analysis. I showed you the diagram just so you know that it's quite rigorous as a study on decision analysis. But essentially what they found was if you take a deep breath and you go ahead with vascular surgery in the face of a patient with some angina, that actually is not that bad compared to if you do all the angioplasty, angiography. The only group that actually had a higher risk was a group of patients where you know there's inoperable coronary artery disease when you've done all the investigations and you still go ahead with the surgery, then you end up with a higher mortality, 3.8%. And the reason for that was simply you're subjecting the patient to additional risks, angiography, whatever coronary revascularization procedure, and at the end of it, you do the index surgery. So you're subjecting the patient to 3 risks as opposed to just take a deep breath and do the surgery. That was 1995. So it's sad that we haven't really come that far in how we can optimize. Oops, I think I might have jumped. Anyways, the American, okay, now the only new piece of evidence that has come up, and I apologize, I seem to have trouble controlling the slides. The only new piece of evidence that has come up is a recent article, and the American Heart Association guidelines actually refers to it. When the patients have an acute MI, and then they go on to have either a PCI or some sort of angioplasty stent versus a CABG, and then they come for surgery, a non-cardiac surgery. If it is done within a month, the risk is much higher. And compared between PCI versus CABG, CABG is actually much better in terms of reinfarction. And so what does that mean? Well, that means, number one, we should delay the surgery to 2 months if someone has an acute MI and then they have to come for surgery. At least 1 month, if at all possible. It also suggests that maybe if someone has an acute MI and you have to do a procedure, a CABG might be better off. But the evidence is still just one study, maybe still weak, and certainly the Heart Association did not put that out as a recommendation. They highlighted that there's something there that we need to look at. What is also important for us to know is that this is in a group of patients with acute MI, and then you decide what to do. That's quite different from somebody who has angina coming for a non-cardiac surgery, and then you decide what to do. So those are 2 different denominators, 2 different populations. So don't confuse the finding of this study versus what I just said in the last 4 slides. So what the Heart Association has done is to classify the level of evidence. And class 1 is randomized control trial. Class 2 is number of studies. Some are for, some are against. 2A is in favor. 2B is maybe not so in favor. 3 is definitely it may do harm. And the level of evidence is also classified into A, B, and C. And A is definitely, it's broad spectrum, number of randomized control trials. Level B is, it's a very narrow population, maybe one single population, colorectal surgery or vascular surgery, and it's not necessarily generalizable to all the different populations. And this is how they look at the evidence. And if you recall the first slide I showed you, For pre-op testing and screening, there was no green box except for one, and all the other ones were yellow, as well as one red, which means very little evidence for class 1. And the class 1, if you look at it closely, is if you find some disease, coronary artery disease, in the pre-op testing for a non-cardiac surgery, what you should do is to determine if the patient's coronary artery disease status warrants any revascularization. If not, you proceed with surgery. If you see triple vessel disease, if you see LV dysfunction, the usual indication for coronary artery intervention, then you would proceed with the coronary artery intervention. If you actually think back in your population, I don't know your practice obviously, but in my practice, the category that actually anyone...
The outline of this short talk is going to be basically concentrating on the magnitude of the problem, the impact of the problem on our patient and practice, and guideline approaches toward the determination of the thrombotic and bleeding risk, definition of the urgency level of the procedure or the non-cardiac surgeries, timing of the non-cardiac surgery, and double antiplatelet therapy care perioperatively. Is there any bridging therapy options available for us, for the anesthetist, for the surgeon, for the cardiologist, and final recommendation. Now, between 5 to 15% of our patients with coronary stents will undergo some sort of a non-cardiac surgery in the first 12 to 24 months after stent implantation. The majority of the non-cardiac procedures are major in the first 12 months. So it's a big problem. It's not really a minor problem. Now, we know from different studies that perioperative risk for acute coronary syndromes is highest in stented patients as compared to plain old balloon angioplasty. So that tells you clearly that the presence of a coronary stent is a problem by itself. It's a solution. It solved a lot of problems for the cardiologist, but it also created more problems for the surgeon and the intensivist and the anesthesiologist in the post-operative care and the perioperative care for patients who are going for non-cardiac procedures. The thrombotic risk is highest in the first 4 to 6 weeks after stent implantation. This goes on for both bare metal stents as well as drug-eluting stents. Now, there are established, well-known clinical and angiographic risk for stent thrombosis that we'll go over briefly. Now, even after 12 to 24 months of double antiplatelet therapy in DES population, there is still up to 3 to 3.5% risk of stent thrombosis perioperatively if we discontinue one of the antiplatelets or both of them for a non-cardiac procedure, and up to 20% of patients who are subjected to this very late stent thrombosis can die or may die. So it's a real big problem, and we had from our practice very, very common examples that we can go over later on. Now, if we want to stratify our thrombotic risk and define who's at low risk and who's at intermediate risk and who's at high risk, patients who are going for non-cardiac surgeries who underwent coronary stents, they are labeled as low risk if at least 6 months has lapsed after the PCI with bare metal stent, so you can interrupt the Plavix or the ticagrelor or the prasugrel, 12 months at least after drug-eluting stents. They're labeled as intermediate risk if the period for bare metal stent is between 1 and 6 months, 6 to 12 months for drug-eluting stents, and at least 12 months for complex PCI. And mind this, most of our patients have complex PCIs, and those are PCIs on left mains, bifurcation lesions, long lesions, overlapping stents, the only remaining vessel, and small caliber vessels in the setting of diabetic patients. Some clinical features that indicate higher risk of stent thrombosis are patients who had PCI in the setting of acute coronary syndrome as compared to stable coronary artery disease, patients who are diabetic, chronic renal failure patients, patients with congestive heart failure, and low ejection fraction of less than 35%. Those are patients who are at a higher risk for stent thrombosis if you interrupt their dual antiplatelet therapy perioperatively and definitely prematurely. Now, this slide is very important. This is adapted from a huge VA registry of more than 40,000 patients who had stents at one stage and going for non-cardiac surgery. I would like you to concentrate on, I think we don't have it, yeah? It's a little bit. If you go maybe here, the last section of this is basically going over the time scale since the stent implantation, and it tells you that the highest risk for major adverse cardiac events if you interrupt dual antiplatelet is in the first 6 weeks, and the major adverse cardiac events is up to 11%. The second important thing, which this slide tells us, that even after 12 to 24 months of dual antiplatelets, you are not immune. You still have 3.5% risk of having major adverse cardiac events, and that includes, as Dr. Yang explained, cardiac death, MIs, heart failures, and so forth. So basically, completing the 12 months of dual antiplatelet does not protect you, and some of us know that very well. And so you have to be very careful with these patients. Now, the other part of this is that how to stratify our hemorrhagic risk for surgery, non-cardiac surgeries. There are so many ways of doing this. This is one of the ways that I find it more comfortable, because I believe with the newer surgical, non-cardiac surgical techniques, I don't think much of this is applicable anymore because of the minimally invasive surgical techniques that's basically being utilized nowadays. With this slide, you can have low, intermediate, and high, and this is basically based on the need for blood transfusion. If you don't have any blood transfusion need, this is a low risk hemorrhagic risk, and these usually are minor procedures, minor orthopedic procedures, minor ENT, biopsies, endoscopies, dental extraction. And I would give you an example of a disaster which was about to happen a few days ago of one of my patients who had a left main LAD CERC stent 4.5, 5 months ago after ACS, and he was going for a lymph node fine needle biopsy. And I don't know whether the anesthesia or the surgeon told him that you have to stop 7 days, both aspirin and the Plavix or the clopidogrel. It would have been a nightmare for whoever is taking care of this patient in the ICU. And the intermediate hemorrhagic risks are basically the majority of our patients, including cardiac surgery. Cardiac surgery is not a very high risk hemorrhagic risk. And we have one of our senior cardiac surgeons in Kuwait here in the area, in the region, and basically they do a lot of open heart surgeries and valve surgeries on both dual antiplatelet, be it ticagrelor or clopidogrel plus the aspirin, with reasonable bleeding risk. And the high hemorrhagic risks are those basically who are in a closed space like the brain, the spinal surgeries, as well as the posterior chamber of the eye. Now, definition of timing of surgery is very important. Is it an emergency, urgent, time-sensitive, or elective? Elective is very easy. You can postpone it as much as possible, at least 1 year. Emergency, patient has to be in the OT as soon as possible within the next 6 hours. Otherwise, he's either going to lose his life or he's going to lose a limb, and anything else is in the middle. Now, we come to the timing of elective non-cardiac surgery in patients who had prior percutaneous coronary intervention. As we said, it is important to give the patient the minimal acceptable period. And these are elective procedures. So if the patient undergoes or underwent a only plain old balloon angioplasty without the utilization of stents, you have to wait at least 14 days prior to any non-cardiac surgeries. And for patient who is gonna go non-cardiac surgery and had a bare metal stent, he has to wait a minimum of 30 days. And patients with drug-eluting stents has to wait at least 1 year. And this can be cut down up to 6 months in selective population of patients who are waiting for the non-cardiac surgeries. More than 6 months carries more harm than the risk of stent thrombosis, especially if the drug-eluting stent was placed in non-acute coronary syndrome status. The same thing goes with the urgent or emergent coronary surgeries, patients who are going for emergency non-cardiac procedures who had the coronary stents placed within the last 4 to 6 weeks. Normally speaking, they should continue their dual antiplatelet therapy, both the P2Y12 receptor inhibitors plus the aspirin. If the bleeding risk is high, then the aspirin is advised to be continued. The other agent can be stopped, of course, with a consensus that there may be a problem, and these types of patients should be taken care of in a facility where you have a cath lab, because if a stent thrombosis happens, you have no time. You either have to go to the cath lab or let the patient basically suffer from a possible fatality. This is the algorithm that Dr. Yang went through. I'm not going to go over this. Now, why do we get into trouble? This is very important. We get into trouble because we request a lot of unnecessary non-invasive testing prior to non-cardiac surgeries and procedures. Lots of our patients, I would say majority of our patients, if you can determine their functional capacity according to guidelines, as per guidelines, do not need further non-invasive testing, including stress tests. What happens in our practice that we see patients showing or coming to the clinic, to the cardiology clinic with a stress myoview showing a small, moderate, multiple small areas of ischemia referred by the anesthesia for cardiac evaluation and coronary intervention. It's not going to make any difference if the patient has a normal functional capacity with excellent functional capacity. We're not talking about low risk procedures. We're talking about intermediate and higher risk procedures. If your functional capacity is good, you do not need to do a non-invasive stress testing to see whether he has a cardiac problem or not. We know from the literature that it's not going to change your mortality, it's not going to change your MI rate if the patient is well treated and stable. So there is no indication. This is what gets us into trouble, and this is what gets us in the trouble of dealing dual antiplatelet therapy management perioperatively in non-cardiac surgery. And this is the most important message I would like to convey as a cardiologist and as an interventional cardiologist, that we do not need to do an unnecessary non-invasive testing on patients who are functional and active and asymptomatic. Thank you very much. 2 minutes only? Okay, fine. I just wanted to, I have many slides. So I'm going to just show you that this problem is I can't see here. Okay, it's a class 3, no benefit, or there is harm. This class is very important because it is not recommended that routine coronary revascularization be performed before non-cardiac surgery to reduce perioperative cardiac event. It's not going to work. It's actually going to make your life more miserable as an anesthesiologist and as a surgeon, an intensivist. And you have one trial here, which is a COP trial, which is the coronary artery vascularization prophylaxis trial, which showed no difference in perioperative and long-term cardiac outcome with or without preoperative CABG or PCI in patients with stable coronary artery disease, with an exception of left main disease or patient with severe ischemic cardiomyopathy or critical or severe coronary, severe aortic valve stenosis. And this, just to continue, just 5 seconds, again, in patients who needs urgent non-cardiac surgery, and you have one of the cases where you need to revascularize the patient, either having a left main or an acute coronary syndrome with severe triple vessel disease, having or to consider CABG combined with non-cardiac surgery is probably preferable than doing or putting a stent if you cannot delay your non-cardiac procedure. And bridging therapy, 1 more minute, it's suitable for patients with very high risk, thrombotic risk, if double antiplatelet therapy is interrupted due to high bleeding risk. There is no benefit from low molecular weight heparin. There is no benefit from unfractionated heparin. Short-acting intravenous antiplatelet therapy with agents like tyrofibam, 2B3A inhibitors, was found to be safe and effective in small studies in very high-risk patients. Cangrelol, although it's supposed to be one of the newer agents, is not approved by FDA for this purpose. This is a vascular surgery scenario combining thrombotic risk versus bleeding risk, and again, the same rule applies. Conclusion: until further solid evidence are made available, it is recommended to individualize the patient's care in the context of multidisciplinary team approach, inclusive of the cardiologist, surgeon, anesthesiologist, and most importantly, the patient, to reach the best management plan for patients who has a coronary stent and going for a non-cardiac procedure. Thank you very much.
The intraoperative cardiac monitoring, cardiac output monitoring rather, it's become quite in vogue, and I think it is important for us to keep a very close eye on this because it's very promising. But there are challenges when we use this monitor, and it depends on the context, what you want me to talk about. First of all, I'm not sponsored by any industry, and I'm not against industry, so this is as subjective I can be in talking about this topic. So the objectives here is that we will review the reasons for intraoperative cardiac output monitoring. So it's not cheap, so it doesn't make sense for us to just slap on a monitor on everybody. So we have to understand why we're doing this, and then we have to review the existing monitors. Now, in 20 minutes, it's very hard for me to give you a very detailed analysis of this, but I will give you a broad overview. And then we'll understand what the variability of cardiac output determinants. So cardiac output is not a single indicator that we can very simply monitor and tell us everything. It is something as a symptom as opposed to the cause. So we have to understand what the cardiac output means. Oh, sorry. Can you hear me now? I apologize. And I will give the sort of the current thinking about the use of cardiac output monitoring. So the reason for cardiac output monitoring is it depends on why you want to use it. In the case of moderate to high-risk cardiac patients, I really don't see any reason to ignore transthoracic echo or transesophageal echo, or even in the old days, and currently still a lot of people believe in the PA catheter. It really still comes down to if you have a high enough risk patient, those modalities still should come back in for you to think very carefully about. In the context of ERAS, which is enhanced recovery after surgery, which has been very much talked about, in the last 10, maybe even 15 years, really the cardiac output is part of the dialogue that we have about fluid management under ERAS. But I want to give the context. It's always important for us to understand why we're doing certain things. ERAS is not about fluid management only. ERAS is about a whole bundle, a whole package of what we have to do. ERAS is about what we need to do, we meaning surgery, anesthesia, as well as potentially internists or other specialties before admission. And then the day before surgery, the day of surgery, and the post-op care. But on the day of surgery, intraoperative fluid management is a key component of ERAS. And this is from one study outlining what the bundle is about in ERAS in 2006. And the same thing about ERAS in other journals, and you can go and look it up. But they emphasize, again, goal-directed fluid therapy and alternative analgesic modalities. Those are key components, or two of the key components, I should say, that affects enhanced recovery. So it's not just the fluid. So we should not delude ourselves to think that if we manage the fluid perfectly, then the patient is going to go home early. Now, the NICE guidelines, which is what is used in the UK, recommended the adoption of CardioQ in 2011. It stirred up a lot of controversies in the UK. Nevertheless, from their perspective, it reduced post-op complications. There was evidence for that. It reduced the use of CVP lines, and it reduced the hospital stay. So what's there not to like? That's why they went with the CardioQ. So what are the monitors that we are talking about? So once you have something like the organization such as the NICE coming up with a set of guidelines like that, it really sort of stimulates the whole discussion. Okay, we need to now use the monitors. So what monitors do we have? Well, we have pulse contour, that is the flow track, or using the arterial line, and then from there you can calculate the pulse contour of stroke volume variability. Now there's also photoplethysmography. I always have trouble saying that word, but I said that one time, nice, okay. Esophageal Doppler, and that's the CardioQ, and as you probably know, that's a Doppler probe put in the esophagus, because it's just a Doppler. It's a very thin probe compared to the transesophageal echo probe, although the TEE probe nowadays is becoming so much smaller as well. So the Doppler beam, the CardioQ, you line up essentially the aorta with the Doppler beam, and you try to measure the cardiac output. There's also bioimpedance, and that is measuring the amount of fluid in the thorax during each cardiac cycle, and the impedance changes. So impedance is a very interesting physics phenomenon, and it's used in many circumstances. So even in volcanoes, people have used impedance to measure whether the volcano and the magma flow increasing, whether it's going to explode. So impedance is a very real and validated concept in many of the physics experiments. And nevertheless, in humans, it's not been that accurate. So then we go on to bioreactance. That's the next level. So I'll touch on that in a sec. The pulse contour is area under the curve of arterial waveform. So you have the arterial waveform, and any of you who still remember your calculus or differential equations, it is integrating the area under the curve for the waveform, and that gives you the pulse contour. And then they can use mathematics to transform the pressure waveform to flow waveform. It depends on three variables. It depends on the aortic impedance, it depends on the arterial compliance, and it depends on the systemic vascular resistance. And you can think of, if you think carefully,